everybody for joining us. Up until now, most of our presentations have been pretty fast paced. They have been focused primarily on the understanding the nature of disasters, understanding last week was how we organize when we all show up as strangers at a command post when we are activated. We've talked about how to prepare yourself personally and how to help your neighbors to prepare. And then we had that first part of fire and utilities training. So now we begin to get into the deep learning with MedOps and how we would respond in the event of a disaster. So please participate to your fullest. You had a number of videos we asked you to watch in advance. I will remind you that I am recording this session, and I sent you on Sunday night links for all of the prior sessions so you can rewatch them. And so without further ado, I'm going to turn it over to Karen, and she will take us through Medical Operations I.
Okay, welcome everybody, and I am going to try and get my screen sharing working here, so give me a moment.
And folks, for this, because it's pretty comprehensive amount of time to train this, we ask you to pretty much keep yourself on mute for this presentation and enter your questions into the chat. I'll be monitoring the chat as we go along. So in case, I'll stop Karen if there is anything, we're completely going off the rails, but other than that, she's going to take questions at the end so we can keep moving.
Okay, how's my screen sharing going?
Very nice.
Okay, so I actually have a few stopping places in my talk for questions, and so if you have questions, please put them in the chat. It's hard for me to see the chat when I'm screen sharing, so Margaret's going to help me keep track of those. All right, so my assignment is to talk about Disaster Medical Operations Part 1. And this is what we call the CERT mantra slide. It's in every deck, so I know you have seen it. And I want to emphasize, as the other instructors have, that personal safety is your #1 priority. So that means, especially in the medical context, that you're showing up prepared with appropriate clothing, footwear, water, and the right PPE. And as you will see, we always work with a buddy, and it's very important, especially in medical, to maintain situational awareness. And as always, our goal is to do the greatest good for the greatest number. So unit objectives for tonight are to identify what we call the 3 killers, which are the medical conditions that require immediate treatment, and they are remembered by the mnemonic A, B, C. A for blocked airway, B for life-threatening bleeding, and C for circulatory collapse, or what medical people call shock. And then the second unit objective is to conduct triage, which is a process that we use to deal with a situation when the number of victims overwhelms the resources available to take care of them. So this slide has been in the CERT deck since forever. And once upon a time, I tried to find out where did it come from. And as best I can tell, this information comes from under-resourced areas in war zones, such as the situation we now have in Turkey. And it turns out after a major disaster like that overwhelming earthquake, a lot of people die right away. But then, especially in under-resourced situations where medical help is not, professional medical help is not coming right away, a lot of people are in fact saved by their neighbors. So as you might imagine, in the medical context, PPE, or personal protective equipment, is really important. And so in addition to our helmet and our sturdy shoes and work gloves, we also need to bring our goggles and an N95 mask and our medical non-latex exam gloves. So the question arises, when do we wear all this stuff? So I would say that anytime you get called out for CERT, you should have all this stuff available. You're not necessarily going to be wearing it. So for example, you certainly don't need your work gloves to pass out flyers at a community fair. But in medical, we want you to be wearing your goggles and your N95 anytime there's a reasonable possibility of getting blood splashes or body fluid splashes or coughed out germs on you. And we want you to wear your medical gloves anytime you're going to touch a survivor, and we need to change gloves between every survivor. Goggles need to be what we call indirectly vented. And you can try and look up these online, look at pictures, but basically what's going on here is that the air takes kind of a circuitous path from the outside of the goggle to the inside near your face. And the idea is that that makes it less likely for a particle or a germ to land on your mucous membranes in either your eyes or in your nose. So if you're purchasing these on your own, the best way to figure out if they're indirectly vented is to look at the product description and make sure you're buying your goggles from a reliable source. So I imagine that 3 years ago, you could not have imagined that you would know as much about masks as you probably do today. But the bottom line for CERT purposes is that we want you to show up with an unvented N95 mask. N95 masks are so named because they prevent the inhalation of 95% of harmful particles, whether those be germs or smoke particles. Now, they don't protect against everything. For example, they don't protect against noxious vapors. And 5% of a big number is still a lot. So they're not foolproof. They come in two flavors, if you will, surgical and non-surgical. And the surgical masks are rated for protection against blood splashes under pressure. What that means is that if you're doing medical operations or search and rescue or anything where a blood or body fluid splash is likely or even sort of likely, you want to have the surgical variety. If you're pretty sure you're not going to be doing that, let's say you are pretty sure you're exclusively the comms guy or gal, then the non-surgical variety is certainly fine. Probably what we want you to do is have a couple surgical masks just in case. But again, if you're packing a lot of masks, the kind to get depends on what kind of job you think you're going to be assigned to. If you see these square things on the outside of a mask, those are vents. And bottom line, for the vast majority of cases, we don't want these in CERT. A vent is a one-way valve, which means that when you exhale, the valve opens and you can breathe freely. So it's a little easier to breathe out with a vented mask. When you breathe in, the one-way valve closes and the air passes through the filtering material. So what this means is that this mask does a good job of protecting you from particles and germs, but it doesn't protect all the people around you from your germs. So because in CERT, we're usually working in proximity with survivors and other volunteers, for the most part, we're not going to want you to be wearing a vented mask. I could see some situations where if that's all you have, it's going to be okay. So for example, if what you're doing is a windshield survey and your buddy is a member of your own household and the air is smoky and you anticipate getting out in the smoky environment to get better radio transmission, a vented mask is fine and possibly even advantageous because it's a little easier to breathe with. But for the most part, again, we have to work around survivors and other people. So please don't show up with vented masks. If that's all you have, you can kind of get around the situation by taping up the vent. Now, also on this slide are some masks that aren't going to work in the CERT context because they don't provide enough protection. Just in general, so now I'm not talking CERT, I'm just talking about your own protection. What you want for your own personal protection against germs is something with medical grade material, and the tighter fit, the better. So this white mask here on the left is going to be better than the blue one just because the white one has a better fit. I would say that nowadays, now that we have plenty of medical grade PPE, that cloth masks are pretty much for the purpose of keeping your medical grade equipment clean and possibly making your medical grade equipment have a little bit better fit. But you really should not be relying upon a cloth mask these days to provide you with personal protection against germs. Now, as homework, we asked you to look at the CDC video that shows how to put on and take off an N95 mask. And I believe we may have also shown that on Welcome Day. If this is not in your DNA, do it a few times so you get the hang of it. A few things about that video. It was designed for healthcare providers. And so one of the things it says is that an N95 is a one-time use product and you're supposed to change it between patients. That is not true in CERT. In CERT, we get to wear our N95 mask for longer, but we have to do the following things. Every time we put on the N95 mask, we have to go through all the steps in the video to make sure it has a tight fit. So you put your hands around the edges, tighten it up, take a few breaths, make sure that it's not leaking. I have actually made my N95s last for weeks on end during the pandemic, doing it this way. I changed masks. Well, let's say I'm going to the grocery store on day 1 and day 2. On day 2, I'm wearing a different mask than I did on day 1. And day 1's mask is hanging out, letting the wimpy germs on the mask die off. So I rotate masks, but the times I change my N95 are when it doesn't fit anymore, when it's obviously grossly dirty, and if I'm going into a high risk situation, such as getting on crowded public transportation with dodgy ventilation, or let's say I am visiting someone who's immunocompromised. Now, I'm not actually too worried about catching anything from my reused N95, but especially if you've been doing operations all morning, you've got to consider the outside of your mask contaminated. So what that means is no sticking your fingers under your mask to scratch your nose or rub your eyes until you've decontaminated your hands. And you fellas with beards need to know that depending on the style of your beard, the mask may not provide the advertised protection. So if you are employed and have a beard, your employer and you will work out a solution that provides you with good respiratory protection and works for the both of you. In CERT, we're going to ask you to consider the risk to yourself and to the people around you. So we are not going to chase you fellows with beards with our razors, but if you are taking on a high-risk job, and high risk means either to yourself or to the people around you, then shaving would be a way of mitigating the risk from an improperly fitting N95. The other thing that we always say is that if you have significant cardiorespiratory disease, you should check with your own doctor to make sure it's okay for you to wear an N95. In the vast, vast majority of cases, the answer will be yes, because there are good studies to show that wearing an N95 does not pose a significant hazard, even if you have severe respiratory disease. This used to be the most important slide in the medical deck. It was the hand sanitization slide. And again, if putting on and taking off gloves is not in your DNA, practice a few times so you get the hang of it. We often get asked, do we have to change gloves between every patient? And the answer is absolutely yes. And then we get asked, well, what if we run out of gloves? And the official answer to that is that Walnut Creek Medical and Walnut Creek Logistics are passionate about making sure that that does not happen. However, and if it does, there are workarounds that I'm not going to go into because this is a basic class, and we'll cross the bridge if we come to it. Now, it's really important that you wash or sanitize your hands after removing gloves with either soap and water or hand sanitizer. CDC actually wants healthcare professionals to use hand sanitizer, and the reason for that is purely logistical. It's a lot easier to get healthcare providers to comply with hand sanitization if they can use a bottle of hand sanitizer that's right outside a patient's room or at the patient's bedside and don't have to go running around the hallways looking for a sink. CDC, however, FEMA would like us to use soap and water unless soap and water is not available. Regardless of what product you're using, soap and water or hand sanitizer, you need to get it all over your hands and rub carefully for 20 seconds, which is the time it takes to sing "Row, row, row your boat." You also need to be aware that hand sanitizer has an expiration date, and that's because the alcohol in hand sanitizer evaporates. And so once it evaporates to the below a certain point, it's no longer reliable for killing germs. And so cheaping out by using expired hand sanitizer is not the way to go. If you repurpose a bottle for hand sanitizer, you want to make sure that you relabel your repurposed bottle with the expiration date of what is actually inside. Now, times when soap and water is mandatory include before and after eating, after toileting, or if your hands are grossly contaminated. And then we have a fairly famous slide, at least among the instructors, which is that if it's wet and sticky and not yours, don't touch it with bare hands. And I would add to that, if you accidentally touched it, be sure that you sanitize your hands. So are there any questions? Okay.
Karen, there was just one comment in the chat from Amy who says, wait a minute, in the hospital, we're allowed N95 masks with ear loops. Just a comment.
Yeah, that's fine. An N95 with an ear loop is still an N95.
Thank you.
Okay, N95 just refers to the filtering material and the fit around the face. And those of folks for you who are in the hospital know that to pass muster once a year, you have to go through a fit test where you put on the N95 of the size that you intend to wear, And then the occupational people come around with this some kind of bottle of something that smells and test to see whether you can detect the smell.
Karen, a couple more questions real quick. Are KN94 masks okay? And a second question, should we COVID test before we go on deployment? If we're negative, can we then use a vented N95?
Okay, so let's do these one at a time. KN95s, I'm not 100% sure about what's KN94, but KN95s are N95s that are produced in China but meet FDA standards. And the main problem with KN95s, there's nothing wrong with them, but the main problem here is that to make sure that you get them from a reliable vendor, because one of the problems, especially during the pandemic, was that people made counterfeit, both N95 and counterfeit KN95 masks. So as long as the vendor is reliable, it's KN95s are fine. The FDA I haven't looked at it recently, but the FDA maintained a list of all the vendors that they thought were providing okay KN95 equipment. What was the second question, Margaret? Oh, deployment with a negative.
Yes.
Okay. The problem with home tests is that they can have false positives. So, or false negatives, sorry, especially early on in the course of an infection. So just like most other respiratory diseases, the time you are most infectious is actually before you're symptomatic. So if you're going to be working in proximity to other people, especially indoors, I would say no vented N95. If it's out, if what you're doing is outdoors and once I was doing a sugarloaf exercise where my job was to be the ham radio relay person on a hill far away from everybody. If that had been a smoky environment, it would have been a vented N95 would have been okay. But for the most part, you can't rely on the home COVID test to absolutely guarantee that you're safe to breathe on other people. Any other questions?
That's it. Thank you.
Okay, so now the next part of the talk is identifying and treating the 3 killers, which we remember with the mnemonic ABC, which stands for blocked airway, life-threatening bleeding, and circulatory collapse, or what medical people call shock. And these are the 3 conditions that must receive immediate treatment. But before I get into the ABCs, let's talk about how to approach a patient. So very importantly, we check the scene for safety. So as you may have already heard, we don't go into unstable vehicles, massively unstable buildings, or situations where there are crowds of massively unstable humans. And I don't mean medically unstable. So we want to make sure that the patient can see you and you identify yourself, something along the lines of, "Hi, I'm Karen from Walnut Creek Community Emergency Response Team. I have some basic first aid training. May I help you?" And patients are free to decline our help. But if you get the sense that they're declining because they're uncomfortable with your gender, or sadly these days with your race, try and get a buddy whose help they will accept. We want to protect patient privacy, which in the CERT context mostly means no loud voices, no gossiping, and no release of information to unauthorized people, such as, and that would include the media. So how do we approach an unconscious person? Well, the law says that if the person is unconscious, we have implied consent to treat. And what that means is the law presumes that if this patient were conscious and sensible, that they would not refuse our help. So we do what's called a tap and shout or a shake and shout, meaning we grab their shoulder and shake them a little bit and say in a loud voice, "Are you okay? Are you okay?" And then if they don't respond, we immediately open the airway and we put our ear next to the patient's mouth and look down the long axis of their body. And mostly what we want to do is see the chest. And we're looking to see if the chest rise. We're listening for air exchange. And you can put your hand on the abdomen to see if the abdomen is moving with respiratory efforts. If the person does not have respirations, what you do is you try again to open the airway using a technique I'm going to describe in just a bit. And if the person has not responded to 2 attempts to open the airway with breathing, then for CERT purposes, this person is deceased. So one of the reasons, let me see here, here we go. One of the main reasons, I think I accidentally, sorry, I resized my document accidentally.
Escape?
No, what happened was when the waiting room thing came up, I was trying to get around it and I just, okay, we're fixed now. So one of the reasons an unconscious person, a frequent reason an unconscious person has a blocked airway is because the tongue, which is just another muscle, has become floppy and has fallen into the back of the throat, and that blocks the air. Okay, that blocks the air from getting from the outside to the windpipe, which is here. So the videos that we have and in training, we will show a maneuver called head tilt chin lift. And with head tilt chin lift, what happens is the rescuer puts one hand on the forehead and tilts the head backwards. And with the other hand, they lift the jaw straight up in the air. And when the jaw comes up, the tongue is attached to it. So that brings the tongue off the back of the throat. And now air can get from the mouth or the outside to the windpipe. But the problem with videos and slides and even mannequin practice is you really don't have a sense of what's going on. So what I'd like everybody to do is put your fingers under your chin behind your jawbone. And notice how the jawbone is kind of horseshoe shaped if you're sticking your fingers in the fleshy part of the chin. So now imagine that you're lying on your back. What you're doing with the chin lift part of this maneuver is you are hooking your fingers underneath the horseshoe of the jawbone and you're lifting it straight up towards the ceiling or the sky. So again, we'll show in mannequins how this is done, but but mannequins aren't fleshy, so they don't really give you this sense of hooking your fingers under the jawbone and lifting up. All right, next of our 3 killers, B for bleeding. You can have blood loss from various different kinds of blood vessels. You can have blood loss from the arteries, which are the vessels that leave the heart. And that kind of blood loss will be spurting or pulsatile, like a garden sprinkler. You can have blood loss from veins, which are the vessels that return blood to the heart. This can still be quite serious depending on the size of the blood vessel that got cut. And you can have blood vessels from the smallest blood vessels can bleed, the capillaries, and there you might have just a little bit of oozing. But more important than trying to figure out what kind of blood vessel is doing the bleeding is figuring out that a person has life-threatening bleeding. So these are the signs of life-threatening bleeding. Spurting, that suggests arterial bleeding, and the heart can pump out a lot of blood in a very short period of time onto the ground. Pooling of blood, big puddles of blood underneath a victim is not a good sign. Soaking of blood through clothes or bandages. So for instance, if you come on a scene where bystanders have already tried to stop the bleeding and aren't doing so well. And then traumatic amputation may be associated with major blood loss. Now, the thing to know about traumatic amputation is that there may not be life-threatening blood loss initially because the arteries are in spasm. But later on, when the arteries relax, there can be severe blood loss. So some authorities recommend that even if there is not life-threatening bleeding, traumatic amputation should have a pressure bandage applied so that blood loss will be contained when the arteries start to relax. In the vast majority of cases, our first approach, and sometimes our only approach, to bleeding control is going to be direct pressure. So here, again, we need to be wearing the right PPE. That means our medical gloves, our indirectly vented goggles, and our N95. We're going to try and locate the bleeding source, which means if you have a long laceration and you can figure out that the bleeding is coming from this end of the laceration and not that end, we're going to apply firm pressure directly to the source or to the part of the wound that's actually bleeding. And because we're not using medicated gauze, we may need to hold pressure for quite a long time, maybe 10-ish, 15-ish minutes. One thing that we want to do if we're having trouble getting control of severe bleeding is resist the temptation to just pile on bandages in an attempt to staunch the bleeding. And that's because bulky layers between the bleeding source and your hands decrease the effectiveness of pressure. So the analogy I usually use at this point is if you want to hurt somebody, do you stomp on them with your high-heeled shoe, the flat of your tennis shoe, or your bunny slippers? And the reason why getting stomped on with a high-heeled shoe is going to be so painful is that pressure is force divided by area. So you're concentrating all the force into a very small area, which is not the case when you apply pressure with the flat of your tennis shoe. And of course, the bunny slipper puts a lot of layers between your foot and the object of your ire. But nowadays, if we can't control life-threatening bleeding with direct pressure, and it's pretty clear that things are going south, and if bleeding is coming from a limb, we move quickly on to a tourniquet. Tourniquets used to be more controversial than they are now because the purpose of a tourniquet is to stop all blood flow into the injured limb. And therefore, if the victim does not get prompt medical attention, all the tissue below the limb or below the tourniquet will die. So it's now been, but it was found in the military and now in several civilian studies that tourniquets have a low incidence of adverse events if the victim gets prompt medical care. And by prompt, we mean within 2-ish hours or so. And that would include tourniquets that are applied by relatively untrained lay people. So nowadays, most first aid authorities recommend moving quickly on to tourniquets for uncontrollable, life-threatening bleeding. And even when they were controversial, it was said that it is better to lose a limb than a life. Now, I have to say that the first time I was introduced to a commercial tourniquet, I thought that it was really intuitive and dead simple. But there is now a study that shows that 6 months after being trained in the use of a commercial tourniquet, only 20-ish% of students remember how to quickly and correctly apply one. So there, you do have a video that shows how to use a commercial tourniquet, and you will be shown how to use one. You'll get your hands on one. We'll also teach you how to use an improvised tourniquet. But where the commercial tourniquet is concerned, I would say, based on that study, that it would be a good idea to bookmark it and look at it a couple of times a year, because there may be a commercial tourniquet available and you might be the only person who's been exposed to how to use it. Regardless of what kind of tourniquet you're using, commercial or improvised, these are the general principles. You put the tourniquet between the wound and the heart, 2 or 3 inches above the wound and not over a joint. And the reason for not over a joint is, think of the joint as like a bony box that will prevent the transmission of the tourniquet pressure to the arteries that it's trying to constrict. You twist until the bleeding stops. And for those of you who have not been trained in how to check pulses, that's when you stop. For those of you who know how to check a pulse below the tourniquet, you check for a pulse below the tourniquet. And if you can feel one, then you twist until the pulse is gone, and then stop. And the reason we want people who can check for pulses to check for pulses after the initial application of the tourniquet is that if the pulse is not obliterated by the tourniquet, that means that blood is flowing into the limb, but the tourniquet will make it difficult for blood to exit the limb. And that can lead to one of the more feared complications of tourniquets, which is called compartment syndrome. And that is massive swelling and tissue damage below the tourniquet. We leave tourniquets in plain sight, meaning we don't put bandages and blankets over it. And although there is a place on a commercial tourniquet for a time and date, we would ask you to put a piece of tape on the patient's forehead, write the letter T and the time and date. And the reason for this is that it is less likely that this mark will be covered up accidentally by a blanket. Very importantly, only physicians remove tourniquets when they convert the tourniquet to a more advanced means of bleeding control. Lay people do not take off tourniquets, say in a misguided attempt to figure out if the bleeding has stopped. Okay, in general, we prefer commercial tourniquets, and that's probably because if we're using a commercial tourniquet, we don't have to worry about the quality of material that we're using in our tourniquet. But we will show, and you should know, how to use a commercial tourniquet, or sorry, a improvised tourniquet if no commercial tourniquet is available. The principles here are to make sure that you've picked a material that's wide enough, so at least 2 or 3 inches wide. So in this case, my husband's ugliest tie. You want something that is not stretchy and not stiff. So despite what you may have seen in movies, no leather belts, because not only are leather belts hard to twist, they tend to break when you twist them. You want to make sure that the windlass, which is the stick that does the twisting, is strong.
Recording in progress.
that was so Margaret.
Yeah, folks, as you're coming in, please mute yourself. Karen, there was, due to the wind, there were some power outages in Rossmore and a couple people dropped off. So they're coming back in. I just asked them all to mute. Thank you.
Yeah, I was going to talk to you. I looked at the map about the power outages and I said, good, no Walnut Creek power outages yet. Anyway, so back to the windlass issue. Okay, a weak windlass was one of the main reasons for failure of improvised tourniquets in the Boston Marathon bombing. So you want to pick something that is strong. And something I just learned, the windlass should not be made of polished metal. And that's because there is an additional step to using an improvised tourniquet, which is on the handout that you should have gotten from Margaret. And that is to do something to that secures the windlass so it doesn't untwist. So in this slide here, what we've got is an extra tie, which is not tight, and its only purpose is to keep the windlass from untwisting. And so what can happen if you've got polished metal is that it's more likely to slide, and that could cause the windlass to untwist. Now, of course, it would have been easy to convert this polished metal letter opener to an unpolished metal object with a little bit of tape. In my everyday carry practice, what I have is a dowel, a small dowel that's nice and strong, and at least 2 pairs of gloves. And I've got this pretty much at all times, either in my backpack or purse. And the 2 pairs of gloves are one for me and one for someone that I might recruit to help me. Having said what I did about, I figured that I can always get the tourniquet material from clothing. It's going to be the windlass that's the issue. And so if you don't have access to a nice sturdy dowel, then I would say that probably everybody has a few dead metal pens. And so if you could tape a couple, 3 of those together, those would be nice for everyday carry practices. One other thing to say is that if all I have is a pencil and a polished nail, the nail wins, especially in the civilian context where you're not talking about dragging your casualty around while under fire.
Karen, is there a recommended tourniquet, commercial tourniquet?
The recommended commercial tourniquet, honestly, is, I would say it's find out what tourniquet your agency is using. So Margaret, you have to tell us what's in the SAR bags. And then if you're using one for your own personal use, I would try and get the one that your agency uses. And that's primarily so that you are accustomed to using it. But I believe, so you can, the handout that Margaret has given you with the improvised tourniquet is from the TCCC, which stands for Tactical Combat Casualty Care, and they would have some recommendations for acceptable ones. So Margaret, you just, like I said, you're just going to have to tell us what's in the SAR bags, and I would go with that.
And they'll see that on March the 18th. I will make sure they see an unopened version.
Yeah, and maybe we could look up what the Amazon, not that we're pushing Amazon, but we can indicate like what this looks like on a commercial site. We're not allowed to recommend specific commercial sites, but at least we can show them what it would look like if presented on a website. All right, this is our slide promoting Stop the Bleed training. Stop the Bleed is a national initiative created by the American College of Surgeons with input from first responders and law enforcement. And it was started after the Boston Marathon bombings, because what happened was authorities realized that there were a lot of people who wanted to help the victims of the bombing, but they didn't know how. So they have a website that this is what it is. And like a lot of organizations during the pandemic, they put the initial part of their training online. So you can go there, register, and have a look at the video part of the training. And then there is a link that will take you to a search engine, which will find available courses in your area. So are there any questions about life-threatening bleeding?
Nothing yet.
Okay. And then the last of our three killers is shock, which is ineffective circulation. So poor circulation will result in the tissues not being perfused, and that will result in tissue death, and eventually that will lead to the death of the patient. Types of shock could include massive loss of blood. So there isn't enough volume circulating to be effective. If the heart is not pumping, say after a big heart attack, you have an entity called cardiogenic shock. So the heart is not moving the blood around effectively. And then there's an entity called septic shock. Here, the heart is working overtime to get the blood around the body, but because of the toxins that have been released by the germs, the blood is flowing to all the wrong places. So it's still ineffective circulation. Signs and symptoms of shock can kind of be predicted by common sense based on what I just said. The brain isn't being perfused, so you can have a person who's confused or unconscious or having other mental status changes. The body detects that circulation is ineffective, so the heart rate may increase in response to that. And same thing, respiratory rate may increase in an attempt to get more oxygen into the system. And then with luck, your body will recognize that the brain and kidneys are more important than the skin. So there may be pale, cool, moist skin, or blue lips and fingernails. And unfortunately, nausea and vomiting is a fairly non-specific response to anything bad. But we get to treat anyone who is unconscious for possible shock, since unconsciousness is one of the signs and symptoms of shock. Having said that, there aren't that many treatments that we have in the CERT context for shock. Obviously, we're going to control major bleeding. We can put people in the recovery position, which I'll talk about in a bit. We want to maintain body temperature. And remember, if we're talking about keeping somebody warm, we need to shield them from the cold ground as well as shielding them from the cold air. And we can try loosening restrictive clothing. So now I'm going to talk about recovery position, which was shown on the last slide. The recovery position is a side-lying position, and its purpose is to help someone defend their airway. So as we saw, when a person is on their back, if they're unconscious, semi-conscious, or about to become unconscious, their tongue could flop into the back of their throat and block the airway. If they're on their side, that's less likely to happen. Also, if they have secretion, so saliva, vomit, instead of going into the back of the throat, when a person is on their side, with luck, the secretions will all go on the ground. Especially in the trauma situation, we would like 2 rescuers to put a person in the recovery position, although a fair amount of our training material does show 1 rescuer putting a victim in the recovery position. So for example, if the reason you're putting someone is in the recovery position is that they've just had a seizure and aren't quite with it yet, you know that there's no trauma involved, and you can be pretty comfortable as a single rescuer that you're not going to do this person terrible damage by moving them. Same thing if you saw somebody clutch at their chest and collapse like they had a heart attack, no trauma involved there. You can be pretty comfortable as a single rescuer putting someone in the recovery position. But if there's major trauma involved and it's necessary to put someone in the recovery position, you want to try and get a second rescuer. So why do we, and then we have one other hooker, so to speak, which is that the city of Walnut Creek, and indeed most first aid authorities, do not want lay people moving severely injured patients unless it's absolutely necessary. So absolutely necessary would be a wall is about to fall on your patient, or the building is on fire and you think that you can get yourself, that is priority number one, plus your victim, out safely. All right. Someone who clearly cannot defend their airway during the time they're going to be alone before professional help arrives is someone who may need the recovery position. So that could be a absolutely necessary reason to move somebody. But in general, we as lay people are not going to be.
Awesome. Thanks.
Yeah, saved a lot of time.
You sure did.
Hey, tell me your name again.
Adam.
I'm Jeff.
Can I ask you to mute everybody and then I'll
Yeah,
unmute
so
myself?
cool. Well, have a great show.
Thank you.
Enjoy it.
Hang on
Yeah.
just a minute, Karen. I'm sorry. I'm
Okay.
I'm still working on it, Karen, but you should go ahead.
If you can, when this happens, you can try and unmute everybody and just tell me to unmute. So anyway, where was I? I'm going to try and back up. So again, we're going to, as lay people, we're not going to be moving injured people who might be the victims of severe trauma unless we absolutely need to. But as I said, if it's pretty clear that someone cannot defend their airway during the time they're going to be left alone, that does count as a reason to put them in the recovery position. Another group of people that have special considerations when it comes to recovery position is pregnant women in the advanced stage of pregnancy. So if you have a woman in the advanced stage of pregnancy, even if she can defend her airway, and you're not formally putting her in the recovery position, you actually want to encourage her to lie left side down. So pregnant women, advanced stages of pregnancy, go left side down, unless there's a good reason why not to have her left side down. That would include all her injuries are on the left side. We don't put people in the recovery position on their injured side, or there's some barrier that makes it impossible to turn her on her left side. And the reason for this is if you take a woman in the advanced stage of pregnancy and put her on her side, either side, it takes her pregnant uterus off the great vessels that are returning blood to her heart. And that improves maternal circulation and probably will also improve fetal circulation. For reasons that are not entirely clear, statistically, more pregnant women respond to being placed left side down versus right side down. So just remember, pregnant women go on their side, left side down if possible. And then very importantly, the whole purpose of putting somebody in the recovery position is to make sure that they can defend their airway. So you always check for breathing before you move on. And that's so that any movement that you did doesn't create an airway obstruction that wasn't there in the first place. So here's our slide that shows a single rescuer putting somebody in the recovery position. There are multiple different acceptable ways of getting someone in the recovery position, and there's also several different acceptable recovery positions. I would say learn one and get used to it. So learn the one that is being demoed on training day and get used to it. As far as our training material goes, what I'd like you to do is pay special attention to the video that shows the 2 Australian rescuers, because that video shows how you, as a single trained first aider, can recruit someone with no training whatsoever and get them to help you put somebody in the recovery position when 2 rescuers are needed, because one person has to stabilize the head and neck and the other person is actually doing the rolling. The other thing that video demonstrates real well, I think, is communication between the 2 rescuers. So even if both rescuers were trained, there's really clear communication in that video, and I want you to pay attention to that. And then, as I said, the other thing that I want to highlight is this last bit of the slide here, which shows the rescuer checking for respirations before he leaves the patient. Okay, any questions there?
Nothing in the chat.
Okay, so this is the point where I thought it would be good to take a break.
Can I make a comment?
Please do, Alma.
I think it's important to also note that when you're dealing with what seems to be unconscious person, it is important to speak to them while you do whatever it is you're going to do to them. Because while they may be unconscious, it doesn't mean that they are not aware. And there's no way that you, as the helper, can tell. Even professionals can't tell. So I think it's important to, as you touch them, as you approach them, you should speak to them as if they were conscious, even though they are not. And I think it will help you to deal with them. And if the person is so damaged or traumatized or whatever that they cannot respond, being able to understand what's being done to them will be less traumatizing to them and more helpful to you.
Thank you, Alma. That's great. Thank you.
Okay, so so the question is, do we open the airway before putting someone in the recovery position? And remember that blocked airway is the A in ABC. So unless a person is bleeding out, and I will talk about that in a bit, unless a person is bleeding out, we always address the blocked airway first. Does that make sense? Regardless of what the nature of the injury is, or the condition, or the fact that the person is pregnant, we always address the blocked airway first. Now, once you've discovered that someone is not going to defend their airway because they are unconscious, so they're unconscious, you're going to, if you leave them lying on their back, right? What's going to happen when you leave? The person is, their tongue is just going to flop back into the back of the throat, and very likely they will have the airway obstruction again. So unless there's someone, a bystander or someone, or you are planning to maintain the airway with head tilt chin lift the whole time until professional help arrives, you may need to put somebody in the recovery position and see if that will help. But when you do that, especially in someone who's proven that they can't defend their airway, you need to make sure that that whatever you've done has achieved your goal, which is to have the person still breathing. So, I mean, you could have a situation where they were sort of breathing, or in the supine position, or on their back, and then you moved them and you did something, whatever it is, to cause an airway obstruction yourself. Then you've created a problem that didn't exist before, and you don't want that. Does that answer the question?
I think it does.
Okay.
And the question, so follow-up question, should I worry about getting, bit when clearing the tongue? Having your finger bit?
Okay, so we're in CERT, we don't do finger sweeps, like in, so if you take a Red Cross first aid thing, they'll teach you about various ways to clear the airway, and that would include a finger sweep. That's to clear out debris and stuff like that. You really don't have to worry about getting your finger bit, because when you're doing a finger sweep, I mean, we're not doing this in CERT, but in the non-CERT context, when you're doing a finger sweep, you're talking about unconscious people. And so getting bit is not usually a big problem. But in CERT, we don't do finger sweeps. All right. So if you're doing a finger sweep, you're outside your CERT training. It may be within some other training you have, but you're outside your CERT training.
Okay, and a follow-up question. I did not acknowledge Beth Smith is on the line. Thank you for joining us,
Hi.
Beth. Beth is
Hi,
one of our trainers. Beth has helped, for the new students, Beth is a longtime logistics expert for CERT. And Beth says the CAT, C-A-T, Combat Application Tourniquet, and I will put this in the chat in a minute. It costs about $25. That's the tourniquet we recommend. You can get much cheaper tourniquets on the internet, but beware, they are not CAT and the windlass is not as strong. So I'll put that information in the chat. Thank you, Beth. And then Karen, one more question. As a healthcare person, I have to be certified every 2 years in CPR. Don't I have a responsibility to attempt it when coming upon a person who is not breathing?
Okay, so if you do that, you're taking your CERT hat off. Okay, so in CERT, we teach that we're not going to do CPR on someone who is deceased by virtue of not breathing after 2 attempts to open the airway. Because in CERT, we're doing something a little different, which is we're trying to do the greatest good for the greatest number. And so if you start tying yourself up with doing CPR on a single victim, potentially you are denying your help to other victims around you, because CERT is a response to a big catastrophe. So this question always comes up, and what we say is, if you feel really obligated to perform CPR, just be aware that if you're doing it, you're essentially taking your CERT hat off, and it's a decision you have to make as an individual, how comfortable you feel with going out and being asked to wear that CERT hat the whole time.
And we've talked about that now a couple of times in our classes, how the CERT program is specific and defined. The city or the sponsor of the CERT organization is specific and defined. And so there are professionals who are part of CERT who have greater capability, greater training than what we teach in CERT. But when we're activated, we put the vests on, we put the hat on and the backpack. We are operating within the CERT confines, providing the treatment within the CERT confines. If not, we take that stuff off and we're operating as individuals.
Yeah, and I mean, if you as a healthcare professional say, I just can't imagine myself not doing CPR on an injured patient, then it doesn't say you can't be in CERT, but maybe you should be a radio operator or some other helpful some other helpful member of the team. Okay,
That's it.
so going on to the next part of the talk, we're going to talk about multi-casualty incidents, which are any situation where the number of victims overwhelms the resources available to take care of them. So that would include things like big earthquakes, like the one in Turkey, terrorist events, big pileup of cars, something like a big train derailment. So this slide is in many, if not all of our decks. It's the CERT size up slide. And it basically says that when you go into a scene, you need to have developed a plan, and you need to maintain situational awareness so that if your plan is no longer applicable, that you can change it. So we approach a multi-casualty incident with a process called triage. Triage is a French term meaning to sort. And the idea here is that we're going to sort survivors into people who need care right away, and people who can wait, and then people who are beyond our ability to help. So again, and this goes to the point about the CPR, spending a lot of time trying to save one life could prevent a number of other survivors from receiving the treatment that we can offer. So the system most in use in the United States for triage is called the START system, which stands for Simple Triage and Rapid Treatment. And when we use the START system, we use color codes to indicate the severity of illness, of injury. So we have green patients who are the least likely to need help versus red patients who are the most seriously injured and need help right away. And then we have yellow patients who can wait behind the red patients. And finally, we have Black patients who are either deceased or beyond our help. And so the idea behind triage using this color system is that we categorize the patients as quickly as possible, but very importantly, in addition to quick categorization, we treat only the 3 killer injuries during this phase of operations. So in other words, even our most seriously injured patients, the red patients, the ones who need the help the most, might have a blocked airway and a compound fracture. But during this phase of operations, when we're doing triage, we only treat the blocked airway. We do not splint the compound fracture, even though that's a bad injury. So these are the steps for triage. We do our size up. Essentially, we make sure that it is safe for us to go into a situation, and then we develop a plan. Then what we do is we do something called voice triage, meaning that you and your buddy will stand at the scene and call out in a loud voice, "Walnut Creek Community Emergency Response Team. If you can hear me, come to the sound of my voice." And by definition, anybody who walks out in response to your call is green, meaning that they are the least likely to need medical attention. And then you need to follow a systematic route, which should have been pre-planned, and that route should start where you stand. In other words, you've got a route planned ahead of time. We don't deviate from that route and cross the field to deal with some person who's screaming louder than everybody else. We once watched a EMT graduation exercise where the students missed a survivor that had been hidden in the bushes by the instructor. So we need to make sure that the route that's planned is systematic and includes everything on the site. And then this one is really important. Treatment does not start until you and the patient are safe. So I'm going to tell my war story, and those of you who've heard this talk before know what it is. A few years ago, I took a wilderness first aid class that was aimed at healthcare professionals. And our mass casualty event was meant to be a boat explosion. So what this meant is that the small, under-resourced SAR team that I was part of went down to the beach at the Presidio, where a bunch of my other classmates were in bathing suits in the water in a protected cove at the Presidio, and they were meant to be the victims of this boat explosion. And it didn't help that the SAR team had no communication equipment. So communication was a runner, which happened to be me, running back and forth between the teams in the field and the incident commander on the hill. And so being healthcare professionals, the teams all like rushed into the water, and they discovered horrific injuries such as a sucking chest wound, unstable head and neck. And I was running back and forth between the teams in the water and the incident commander, mostly saying, the team in the water reports that they have this terribly injured patient and no equipment to deal with it. What do we do? It also didn't help that the captain of the boat had survived the explosion and was running around the beach telling us what a bad job we were doing. So in the hot wash, which is the after action analysis, the instructor told us that our biggest and first mistake is that we didn't get our patients and ourselves to safety. So even though this was obviously a protected cove at the Presidio, we were meant to imagine that we were facing the open ocean and that at any time a sneaker wave could have come along and washed a lot of us out to shores or out to sea. So he said, the first thing we should have done is, dire injuries notwithstanding, we were supposed to grab our patients and drag them up to above the high water mark. So that's where I learned treatment does not start until you and the patient are safe. And then what you do is you evaluate and tag each patient according to the severity of their illness. And very importantly, during this phase, you treat only the three killers, which are blocked airway, life-threatening bleeding, and shock. And then you need some way of remembering how many of what kind of patient you have triaged. So you need to know that in triage of this apartment building, I have 3 yellow patients on the 3rd floor and a red patient on the 1st floor, and the red patient is on the 1st floor, not the 3rd floor. All right, reasons for triage not going well: no plan or organization, poor leadership, ignoring personal safety we talked about, deviating from your route to deal with the person who's screaming the loudness, who's off the route. And then again, we treat only the killer injuries during this phase of operations. Treatment of other injuries comes later and may be done by a different team altogether. So I said that anybody who walks to the sound of your voice during voice triage is green or walking wounded. These are people who are least likely to need our help. And if they are willing, we can use them as helpers to care for others. We want green patients to stay in a central casualty collection point for further assessment. So in our beach scenario, in the middle of the exercise, that captain who was harassing us collapsed because he was meant to have had a closed head injury and was bleeding into his brain. And had he been sent to the casualty collection point, further evaluation might have detected the signs of his head injury. So resources permitting, we want green victims to stay at a casualty collection point. Of course, we cannot force them to stay there, but that's would be desirable. Now we've got one other point here, which is that the START algorithm was developed before the emphasis on identifying and treating life-threatening bleeding. So we have an addition to the START algorithm as it was written in the 80s, which is that if at any time you detect life-threatening bleeding, you drop what you're doing and treat the life-threatening bleeding first. And that's because someone can survive a blocked airway for 5 minutes, and they can survive shock for even longer, but they can bleed out within seconds. Now, there's another corollary to this, which is that you'll see in the START algorithm that we may decide that somebody is red, the most severely injured, before we've done an assessment, a formal assessment of their circulation. So before we move on to the next victim, we always do a quick scan for life-threatening bleeding. This is a little different than what you may have learned in other first aid classes, especially if you're a professional, where you're supposed to strip the patient down and look for bleeding. This is not what we're doing here, because we're trying to go as quickly as possible from one survivor to the next. What we're doing is we're going to take a quick look for life-threatening bleeding that somehow we didn't observe on our first go around, and make sure we treat that before we move on to the next victim. So this is the START algorithm or for assessing a patient. It has 2 mnemonics, RPM and 32 can do. And the RPM stands for respiration, perfusion, and mental status. And it will be pretty clear what 32 can do means in a bit. One thing that you can remember is that because of the mental status part of this assessment, anybody who is unconscious is going to be red by definition, and that will help you with the kind of in a mental sense or in a cognitive sense, but even if it doesn't help you with the physical steps of doing the RPM tests. So we're going to start with the R part of RPM. And what we want to see for the R test is that an adult is breathing at a rate of under 30 breaths a minute. So that's 1,000, 1,000. That's about 1 breath every 2 seconds. Children's target range is a little faster, 15 to 45 breaths a minute. And for the purposes of START, a person is a child if they look like they're younger than a teenager. Now going on to elaborate on the R, as I said, if it appears that the person is unconscious, you open the airway twice using head tilt chin lift. And if they are not breathing after 2 attempts to open the airway, then you are to tag them as black and move on to the next person. Now, officially, according to the official algorithm, respirations have to be effective in order to count for the R. So in other words, if someone is making respiratory efforts that move their muscles but no air, then and you've made 2 attempts to open the airway, their respiratory rate is 0, and you're supposed to tag them black and move on. I would say that I realize that it will be uncomfortable and maybe difficult for a layperson to figure out if respirations are effective or not. So if you're not sure, I would go ahead and count the respiration. Very likely you will end up tagging this person as red because most of the time such a person with ineffective respirations will be unconscious or semi-conscious anyway. But let's say that's not an issue, that respirations appear to be effective. Then what you do is count breaths. And as I said, what we want to see for an adult is that they are breathing slower than 30 breaths a minute. So again, not. Now, again, the algorithm says that if they are breathing too fast, you tag them red and put them in the recovery position and move on to the next person. But remember that we have a couple of provisos. Number one is we're going to do our quick scan for life-threatening bleeding because we haven't done a formal assessment of perfusion yet. And also remember that as lay people, we are not supposed to move severely injured patients unless it's absolutely necessary. So having said that, if it's pretty clear that the reason for failing the R test is that the person is not going to defend their airway when they're on their back, that is a reason to put them in the recovery position. If their respirations are within the target range, so they're breathing effectively at less than 30 breaths a minute if they're an adult, then you go on to the next test, which is P for perfusion. But before I go on to the P for perfusion, I want to ask if there are any questions about the R test. And the reason I'm stopping here is because of all these, well, what if the respirations aren't effective, or can I move someone into the recovery position if I'm not supposed to move as injured patient and such and such and such. So any questions?
Not specific about breathing. There was a question again. During triage, are you changing new gloves for each patient, and are you hand sanitizing in between?
Yeah, it doesn't take that long. You can do it you can do the hand sanitization on the way to the next patient, and you are definitely changing gloves. We specifically asked the professionals in Contra Costa County, what's the policy? And they change gloves between patients. And you would, if you were the survivor, you would want them to change gloves. So we're going to change gloves. Okay, moving on to the next test, which is P for perfusion. What we want to see here is reperfusion in under 2 seconds. So we check for reperfusion using what we call the Blanche test. So everybody take a look at your thumbnail, and with your other hand, pinch the base of your nail. And notice how when you pinch your nail bed, the pink color underneath the nail bed goes away and your nail bed turns white. And now let go and see that the white color goes away and and the pink color comes back. What we want to see during the Blanche test is that that pink color returning happens within less than 2 seconds. That's called capillary refill. So we want to see capillary refill within 2 seconds. Now, we always get asked, well, what if I can't see the nail bed because the person is wearing nail polish, or it's dark and my headlamp isn't cutting it for some reason? If they're wearing nail polish, you can try using the palm of the hand to do the Blanche test. And if you really can't see, then you can try feeling for a radial pulse. And if there is a radial pulse, then they pass the perfusion test. If there's no radial pulse, they don't. Again, what we want to do is, especially now that we know there's poor perfusion, we want to treat obvious severe bleeding. Again, we're supposed to put the person in the recovery position, remembering the cautions we have about moving severely injured patients. We tag them as red, and we move on to the next person. Now, if they have passed both the R test and the P test, then we go on to the next test, which is M for mental status. So the mental status target is, can they follow a simple command? So for the purposes of triage, if they can follow a simple command such as squeeze my fingers, then they pass the M test. If they cannot follow a simple command, then again, they flunk the test, you tag them as red, you put them in the recovery position and move on to the next person, again, with our quick scan for bleeding and with the reminders that we don't move severely injured patients unless it's absolutely necessary. So if they pass all 3 tests, respirations are less than 30, perfusion returns within 2 seconds, and they can follow commands, that's where our 32 can do comes in, then you tag them as yellow. And again, we always do a check for severe life-threatening bleeding before moving on to the next person. So once again, the mnemonic, RPM, 32 can do. We're looking for respirations less than 30 in an adult. Capillary refill returning within 2 seconds and able to follow simple commands. If they fail any of these 3 tests, they are red. If they pass all 3, they are yellow. So putting it all together, we do voice triage, and the people who walk to the sound of our voice are green, the so-called walking wounded, and they're least likely to need our help. Now, other reasons to declare somebody black, besides not breathing after 2 attempts to open the airway, is if they are obviously dead. So someone who's decapitated, for instance. If they are pulseless with no respiration. If they have mortal injuries, and here we mean an injury that's so severe that it's not going to be handled with the resources available in a reasonable amount of time. So something like an abdominal evisceration where all the abdominal contents are spilled outside the body and there's no professional help coming. Other terms for Black patients that may be used in other jurisdictions include deceased, morgue, non-salvageable, and there's one that gets used by the military and an increasing number of other jurisdictions, and that's expectant. We don't move Black casualties from mass casualty sites because they're considered crime scenes. So more review, putting it all together. The red victims are those who are alive with life-threatening injuries, and they're the ones who fail any of the RPM 32 can-do checks. They require urgent care, but again, during the triage phase of the operation, when you're on the triage team, you treat only their killer injuries. So again, if they have a blocked airway and a compound fracture, we treat their blocked airway. Somebody else splints their compound fracture. And still in review, the yellow patients are those who may have serious but non-life-threatening injuries, and they passed all 3 RPM tests. And so at this point, I'm going to pause and direct some comments to you folks with medical backgrounds who may end up as medical team leaders. It should be obvious to you that the START system does not differentiate your red victim with a gunshot wound from your red victim who may have, let's say, a traumatic amputation, but whose bleeding is under control. And it doesn't differentiate your yellow victim with a compound fracture from your yellow victim with a sprained ankle. So what you as the team leader will need to have some sense of which red victim is more severe than the other red victims. and which yellow victim is more severe than the other yellow victims, because when the professionals show up, one of the first questions they're going to ask is, which person do I put in the rig first? So again, if you end up in that position, try and have some sense of using your professional judgment of which victim goes on the rig first. Okay, now we asked you as pre-class homework to look at a video that the instructors call the bus video. And you saw in this video that a firefighter triaged his way through a busload of crash victims. This video was made in the 80s, about the same time that CERT was developed. And actually what it was meant to do was show other professionals that you could organize a chaotic mass casualty scene very quickly using the CERT system. So it was developed before our emphasis on identifying life-threatening bleeding and identifying the 3 killers in general. But there are some problems with the bus video as regards CERT, and that's what I want to talk about now. So let's start with scene size up. So you will remember in the bus video that the firefighter used an axe to gain access to the bus by breaking a window. In CERT, we are not going to do that. That's too dangerous a situation for us to get into. So remember, our safety is like the #1 priority. The next thing is that you may remember this this victim here. The banner that rolled across the screen said, "No respirations after repositioning the airway. Tag black, move on." All right. If you will remember, the firefighter did head tilt, but he didn't do chin lift. And in CERT, we're going to do both, because the combination of head tilt, chin lift is more effective in opening the airway than head tilt alone. So for CERT purposes, that was not an adequate attempt to open the airway. Then the other thing is to take a look at what PPE this firefighter is or is not wearing. No N95 and no goggles, which we will want you to wear when you're in close contact with injured victims because of the possibility of blood splashes. He is wearing his medical gloves, but we didn't see him change gloves between victims. And as I said, nowadays, even faced with a lot of dire injuries, the professionals will change gloves between victims. And again, if you were a survivor of a disaster, you would actually want them to change their gloves. All right, and then I don't know if you remember this lady here, but she looks pretty out of it. And the firefighter directed a bystander to said something to the effect of, "Oh, she looks like she's bleeding pretty badly. Here, take this rag and hold compression." I didn't see the firefighter check for respiration, but and because this video was made when it was, they didn't show a picture of the bleeding. But let's give the producers the benefit of the doubt and say that the bleeding was meant to be life-threatening and we need to do something about it right away before we do our respiration check. In CERT, we're not going to pass the responsibility of dealing with life-threatening bleeding to an untrained bystander. So we're going to take care of that ourselves. And what that most likely means that one of you, the two of you, so you're with a buddy, is going to do direct compression while the other person checks for respiration. Now, if what happens is you've got a willing bystander who says, I took a stop the bleed course, I can help you with controlling life-threatening bleeding, well, by all means, accept their help. But again, when you enlist bystanders, you need to make sure that they're willing. We don't get to just order them around. And the other thing is that you will notice that the firefighter did not give the bystander any kind of PPE. So if we're enlisting bystanders, we want to at least give them a pair of gloves if we're asking them to hold compression on a wound. Finally, let's say that you have got the bleeding pretty much under control, and you're going to pass this the task of direct pressure on to a not super well trained bystander. You don't tell them just, oh, here, hold compression. You need to say, okay, put your hands or fingers right here and press hard and do not let go until the paramedics arrive. All right, and kind of in general, one of the problems with the bus video from a CERT standpoint is that we didn't see much in terms of identifying the 3 killers and treating them. There was some repositioning of the airway, although not necessarily with the correct technique. And there was bleeding mentioned, but it wasn't clear or it wasn't crystal clear that this was life-threatening bleeding. And we never saw anybody put in the recovery position for possible shock. Now, I can't quibble with that last one because think about it, this firefighter was clearly like the first person in the team on site, and the rest of his team was obviously right behind him. So it didn't make sense for him to be putting people in the recovery position. So by way of more review, we do our scene size up and develop our plan of action. We conduct voice triage, and we should have developed a route that starts where you stand and is systematic. We evaluate everybody who didn't walk out with RPM, and anyone who flunks any of the RPM tests is red, everybody else is yellow. The only treatments we do during this phase of operations are treating the 3 killers. And then again, we have to have a way of remembering how many victims of what kind are where. All right, any questions before we move on to the exercise?
No questions in the chat.
Okay, great. So this is our start tabletop or paper exercise. And the county instructors redid the curriculum a little bit ago. It's actually a couple of years ago now. And we tweaked the victim description somewhat, but we didn't change the scenario, which is the scenario that's been in use by La Marinda CERT for a very long time. If you look at this scenario is actually a little problematic as far as I'm concerned from a CERT standpoint, because it says that we're approaching a scene with a crash bus, there are cars on fire, and there are first responders, like professional first responders, already on site. And I can tell you pretty much we are not going to be doing triage in this situation because it's not safe for us to go into, or it doesn't sound safe to me. And the professional responders are pretty much going to tell us that we're in the way. So what they may be able to use our help with is almost in a non-CERT capacity is as willing bystanders to help if they're overwhelmed, but they're not actually going to want us to do triage in real life. So we have to imagine that all of our victims are or that our setting, our scenario is safer for us. It's safe for us to go into. And let's imagine that professional help is on the way, let's say within 5 to 10 minutes. So now I'm going to go through a few of these victims. And I'm going to try and enlarge my screen here.
And while you're doing that, I'm going to reemphasize that another problem with that, we should change that exercise, but we would never be involved unless the city of Walnut Creek had
Unless the city
activated us.
mobilized. us.
Yeah.
So, okay. So, so in our defense, we had the same scenario. The victim descriptions were pretty much the same, but our scenario was a moderately damaged apartment building or something like that. So it was safe for us to go into. All right, let's start with a 30-year-old man with a compound fracture. Oh, sorry. One other thing about this exercise. You get all 3 RPMs, even though during using the START algorithm, you might stop before getting all 3. But that's just the way the exercise is written. So 30-year-old man with a compound fracture of the left leg, bleeding moderately, respirations 24, capillary refill less than 2 seconds. First question is, how do you categorize this person?
And folks, you should now see a polling quiz. So please mark what you think the answer is for that victim. And no, I don't see anybody adding. Folks, are you seeing the poll?
Yep. I'm seeing it.
Okay. All right. So
Oh, very good. Okay, very good. So like 91% of you said yellow, which is correct. So Margaret, you can, oh, let's see, can I?
So interestingly, I'm not seeing any answers. So that's going to be hard for me.
On my screen.
Yeah, so you'll just have to tell me
Okay.
in the poll. And
can you close it? Because I don't think I can close it.
hang on.
But anyway, while Margaret's closing that, let's think about this. So the person passed all 3 RPM tests, right? So they are yellow. Respiration below 30, capillary refill less than 2, follows commands. All right, the next question is, what is your next move? So Margaret, can you put that one up? Okay, so let me move this into here because we're screen sharing. So the next question is direct pressure, tag yellow and move on, tourniquet. Okay. So I am actually going to, I actually have the next step as B, which most of you, the majority of you got, tag the victim yellow and move on. And the reason is that this patient was described as bleeding moderately. Okay, so I need to move this into there we go. This patient is described as bleeding moderately. So that's not life-threatening bleeding. Remember, during triage operations, we only treat the 3 killers. So if this person had life-threatening bleeding, we probably would have ended up tagging them red. But we would also have stopped to treat the life-threatening bleeding. So since there is not life-threatening bleeding here, then we don't treat that, even though it looks nasty. We tag the victim. We will do a quick scan for life-threatening bleeding, let's say from another source, but we're going to tag them yellow and move on. All right, let's go to our second second victim, which is, let's see here, which is an 18-year-old man complaining of chest pain and shortness of breath, respiration 40, capillary refill 4 seconds, follows commands. How would you classify this person?
And Karen, just to clarify, you've gone to the 18-year-old male on question number 3, not question number 2, the 18-year-old female.
Yeah.
Okay, so we're answering question number 3, folks.
Okay, so your poll isn't up, Margaret.
Sorry, just a minute.
Well, while you're just, while Margaret's putting up the poll, you can think about the answer. Margaret, if you don't get, oh, there we go.
Now, I'm telling you, it wants to, it does not like the idea that we're using the same question over again.
Okay, so we'll skip that in that case. And we will just say, well, something happened.
I relaunched the poll, so now you should be able to vote.
Okay, so well, let's go over this again, because so 18 years. So what is the mnemonic for this patient? I'm sorry, for triage. So let me move this. Let me move the poll out of the way. Okay, respiration 40. Okay, the mnemonic is 32. Can do. Respirations below 30, capillary refill less than 2 seconds, follows commands. So anybody want to change their vote? I don't know if we can change it. You can change your vote. But okay, so this person is red because they would have been red like kind of right off the bat, because let me move this thing. They got respiratory rate of 40, which in an adult is too fast. All right. And if somehow you miss that, their capillary refill is 4 seconds, too long. Right. But we would have classified them red right off the bat just by virtue of their respiratory rate being too fast. Okay. Margaret, you're going to put up the next question, which is what's your next move for victim number 3? Oh no, that's not the right victim. That's question 3, but this would be question 2.
Okay. Okay.
Sorry.
That's all right. All right. I'm going to end that poll. Well,
Okay.
I'm sorry.
Well, to be fair to Margaret, we haven't tracked this before.
Karen, you know,
Okay, that's okay. Why don't I just read
let's
some
talk
answers?
through them. Yeah.
Oh, okay, I'll just read some answers. If you can bring up the thing, that'd be great. And if you can't, but okay. So that question that you just launched, that's for the next person anyway. So
Yeah.
okay.
Okay.
Okay. So let me close this. So you want question 2. All right. So what would just think about this on your own. What's your next move? Up, here we go. Great. Okay. So this is our 18-year-old man with a respiratory rate of 40 and capillary refill of 4 seconds. What's our next move? Quick scan for, okay, quick scan for life-threatening bleeding, tag red, move on. Okay, call the command post with the victim status and location, put the person in the recovery position. Okay, so actually the La Marinda instructor and I went, went over this one, and we thought that the correct answer is quick scan for life-threatening bleeding and move on. and not, even though the victim is red, we're not putting the victim in the recovery position. The reason is that in this scenario, at least the scenario that Lamarinda's CERT had, there were professional rescuers on site. And even in the scenario that I said, well, imagine that help is 5 to 10 minutes out. All right, this person is breathing too fast, but they're breathing and they're conscious. So the probability is that this person will defend their airway. And then they've got chest pain and shortness of breath. So in a trauma situation, that could be due to a serious injury. So our feeling was that we would not put this person in the recovery position because help is on the way in a short period of time. And because this is a trauma situation, we don't want to run the risk of moving someone with a potential chest injury unnecessarily when it looks like they can probably defend their airway for a few minutes. Right, so we thought the correct answer is quick scan for life-threatening bleeding, tag red, move on. All right, so now we're going to do the third victim. Let's see which oh, rats.
75-year-old male.
Yeah, no, it's not. That's not the problem. The problem is I can't close it because I moved this thing. Okay. So when I'm doing the screen sharing, it's my job to, it turns out it's my job to, whoops, wait a minute here. I'm going to move this. Turned out it's my job to close the poll in. Okay, 75-year-old man lying on the ground, gurgling respirations after Margaret, if you can launch, I don't know if you can launch that. Yeah, there we go. So 75-year-old man lying on the ground, gurgling respirations after 2 attempts to open the airway, capillary refill greater than 2 seconds, unconscious, unresponsive. So how do you classify the patient? Okay, so I will say that all of you got this right, regardless of whether you said the person was black or red. The purpose of this question had to do with deciding that respirations were effective or not. So I have to say that my first response when I first saw this question was, oh, this person is red. Like I'm a chest physician, like where's my suction machine? But the Lamarinda instructors defined or set up the question the way they did to suggest that this person had no effective respirations after 2 attempts to open the airway. And especially in a situation where help was not rapidly on the way, this person would be black for CERT purposes. But I will have no problem in saying that if you're not sure that the respirations are effective or not, that you go ahead and count them. And in this case, obviously the person would end up red because you've decided that you don't know if their respirations are effective or not, but they meet the red criteria based on the capillary refill and then and the fact that they're unconscious. So next question. So this is question number 3, Margaret. How would you, what's your next step? So I'll start reading it while Margaret finds the poll. Quick scan for life-threatening bleeding. Okay, great.
No.
Oh, you have to launch it.
Yeah, I have to launch it. Yeah.
Oh, whoops. Okay, you know what, Margaret? Wait a minute, slide it. Oh, this is victim number 6. Oh yeah, got it. Never mind. So again, I'm going to say that everybody got this right, depending on whether or not you thought the person was black versus red. All right, if you thought that the person is black, then you tag them black and move on. So you're pretty sure that if you've decided that respirations are ineffective, help is not anywhere nearby, tag black and move on. If you thought the person was red and there's help, and especially if there's help immediately behind you, or well, maybe not immediately behind you, but let's say 5 minutes out, a case could be made for putting the person in the recovery position. So, so I'm going to say either one, depending on whether you thought the person was red or black. Okay, let me see here. See, how do I move this? Oh, here we go. Uh-oh, how'd I do that? Okay,
Look-
so this will be
Question 4.
question 4.
Okay.
Right. Okay, so 64-year-old woman, 60, let's see if I can make, well, 64-year-old woman walking around crying. Move this. 64-year-old woman crying, no injuries seen, respiration 24, capillary refill less than 2, follow simple commands. Okay, how would you classify her? Okay, good. Most of you, well, okay, most of you got this right. She's actually green, even though she didn't respond to the voice triage because she's walking. Maybe she just didn't hear you the first time around. Maybe she's a little bit hard of hearing or something like that, or was distracted, but she's walking. So that kind of by definition makes her green because she passes all the other RPM tests. Okay, and the next question, Margaret, that would be number 4. So your next move, okay, okay, good. So the next move is to guide her to the collection point. Now, it would be nice to try and find a relative or friend to comfort her, but when you're on triage, you don't have time to be doing that. So when you're on, when you're on triage, as opposed to maybe some other CERT context, okay, you want to do the thing that's like the quickest. And so guiding her to the collection point, enlisting the help of a green volunteer is what you do. You don't take time off of triage trying to find a real friend or a real relative. Okay. Next question. Next question is 7-year-old girl with a below the knee amputation, moderate bleeding, respiratory rate 38, capillary refill less than 2 seconds, follows commands. How would you classify her? Okay, so this is one of our trick questions. Did you notice that the respiratory rate for a child is between 15 and 45? So she actually passes all 3 RPM tests, and technically she is yellow. All right, so what is your next step? So let me see here. Let me fix this for Margaret. Okay, tourniquet, pressure dressing, tag yellow, move on. Okay, so this one's this is actually one of our trickier questions. I actually thought that the correct answer is pressure dressing to control the bleeding, because it's described only as moderate. But remember that I said that one of the problems with traumatic amputations is that someone can be having less than life-threatening bleeding. The bleeding is described as moderate, but bleeding in a traumatic amputation can be less than life-threatening initially, but when the blood vessels relax, there can be more severe bleeding. So I put down pressure dressing to control the bleeding. A tourniquet is technically not required at this point because the bleeding is not uncontrollable and life-threatening. And I realize that the algorithm says that if you have a yellow victim, we scan for life-threatening bleeding and we tag yellow and move on. But again, this is a little bit of a trick question. I can't exactly fault this answer C, but it is a little bit of a trick question because of the nature of the traumatic amputation.
Now, Karen, we are experiencing high wind again, and Rossmore, we're losing
Okay,
students.
okay. Want to give them a few minutes or
are you asking one more question? Is that?
well, I actually think I had, let me see, I have eight that I've prepared.
Okay. All right, let's.
And we can keep going. We can keep going and they can look at the video. I mean,
That's right. Yeah, I will do a proctored second session for people. Okay. All right, here we go.
What am I on?
You just did the 7-year-old, so are you going up to 6?
Yeah, no, what happens, I've got too many overlapping things here. Let me put this down. Okay. All right. 20-year-old woman with an abrasion to her forehead, 8 months pregnant and in labor. Respiratory rate 36, capillary refill less than 2, follows commands.
So I don't know if they're seeing it. I'm not seeing it.
I just put it on my screen share. So
Folks, are you seeing a description of a 20-year-old female?
you won't have the description.
21-year-old.
Oh, 21. Got it.
Okay. So let me go over, so let's go over her, the RPM tests again. So she's got a scrape on her head, but she's following commands. Respiratory rate 36. Oh, sorry. I did put, okay, sorry, never mind. Capillary refill less than 2 seconds. Sorry. I misread something. Okay. So she's red, and why? Because her respiratory rate is 36. So she's an adult. So that's above the, remember, 32 can do. So her respiratory rate is faster than we want to see. All right. And what is your next move? So this would be question number 6, Margaret. So call the command post to tell them we have a pregnant lady who's delivering, or put her left side down, or put her on the recovery position in either side. Okay, so the correct answer is the one that most of you picked, which is encourage her to lie left side down. We don't interrupt the triage process with unnecessary calls to the command post, because we're actually trying to move from victim to victim as quickly as possible. Now, this isn't obvious from any of the resources we've given you so far, but actually what you do is actually after you finish triaging a scene, you are taking, you as an individual are taking notes, maybe on a piece of tapes, but you're doing something to remember that you have like this many red victims and kind of where they are. And then you finish triaging the scene and you meet with other triage pairs, other buddy pairs, and you all get together and you file a field team report. And that's where your overall team leader says, okay, how many red victims did we find on the scene and where are they? And how many yellow victims are there and how many green victims do we have at the collection point? And that's the point at which the whole bunch of you reports, actually in Walnut Creek, what we report is number of red victims and number of yellow and green victims. We have other ways of communicating to the teams behind us exact locations. We can use our field team report to report special circumstances such as lady in labor, but we don't interrupt the triage process to make reports to the command post until we're all done triaging the whole scene. And as we said, pregnant ladies go left side down if at all possible. Okay, so, all right, so I think I'm up to number 7, which is on the next page. So question number 7 is a 20-year-old man with a large scalp laceration, bleeding heavily, respirations 24, capillary refill less than 2, follows commands. I have to actually move. Okay, so this is another one of our kind of trick questions. This person is actually yellow. And the reason, So this is something that you folks with medical backgrounds probably recognize, but the reason we have this one in here is to tell folks that people with scalp lacerations can have a lot of bleeding, or at least it looks nasty, but it's very rarely life-threatening. So actually this person passed all the RPM tests. Respirations are below 30, capillary refill less than 2, follows command, so they're actually yellow. So I need to move this here. Okay, and what's your next step? Okay, maintain direct pressure, ask victim or bystander to help maintain pressure. Tag yellow, move on. So again, okay, so this is good. Most of you got this correct. The correct answer is that this person is yellow. And again, even though the bleeding looks nasty, when we're doing triage and not, like subsequent treatment, we do not want to tie ourselves up, our triage team up, maintaining the direct pressure ourselves. So in this case, what we could do is give the victim or a green bystander some gauze, and if it's a bystander we're asking to help, we'd give them some gloves and say, here, why don't you help this fellow here maintain pressure on this scalp wound. But we as a triage team, we don't want to tie ourselves up doing direct pressure on a non-life-threatening bleeding situation. Okay, and then this is our last patient. Let me move it here. Okay, 28-year-old man with abdominal pain, respiratory rate 24, capillary refill greater than 2, follows commands. So how would you classify the person? Okay, so let's go over these vital signs again, or these RPM things again, and see if anybody wants to change their vote. Respirations 24. So remember, the mnemonic is 32 can do. So respirations are 24. Capillary refill is more than 2 seconds, follows commands. Okay, so I don't know if you can change your vote, but mentally, if you want to change your vote, this person is red. Because why? Because their capillary refill is too long. It's more than 2 seconds. Remember, we want to see capillary refill means that it's taking a long time for blood flow to show up. So this person flunks the P test. All right, and then the last question. Okay, what's your next move? Okay, so this is another question that was meant to be to be a bit of a curveball. So most of you got what I think is the correct answer, which is quick scan for life-threatening bleeding. Now, whoops. So what we were trying, so this is a trauma situation, and what we are trying to imply is that there might be abdominal or pelvic or even chest trauma to account for the abdominal pain. We're meant to understand that help is coming fairly quickly, and the person can follow commands and their respiratory rate is within the target range. So again, following our instructions not to move trauma patients unless absolutely necessary, help's on the way. I'm a little uneasy with putting the person in the recovery position. All right, but you had to use a certain amount of judgment to decide that that severe injuries were not suspect. Okay, so that was a bit of a trick, civic, a bit of a trick question. And then answer number C. Answer number C is a correct answer, but not necessarily for this patient. So if you ever have evidence of high impact severe head trauma, unless the person cannot defend their airway, obviously is going to succumb to a blocked airway if you leave them alone. We try and leave people with severe head and neck injuries in a position of comfort. And studies have shown that patients with that kind of injury, usually, if they're awake, they usually know what's the best position for them to assume to protect their head and neck. Okay, that's all the questions that I had planned to go over. So I'm going to stop my share. Oh, wait, I'm not going to stop my sharing. Let's see. I have our a couple final slides. So first off, are there any questions?
No more general questions in the chat.
Okay.
Karen, I do have one.
Yeah.
In a trauma situation, a multi-casualty situation, if patients are extremely anxious, frightened, I'm a little concerned with the 30 respiration rate. I recognize I will still use it, but I've certainly seen lots of patients that get anxious and are hyperventilating, and yet they're just anxious.
Yeah. The question speaks to like how do we know that this system is effective? And so I re-looked this up right before I got ready for the talk, in other words, a couple weeks ago. And amazingly, as with a lot of things in medicine, there's not a lot of data. And so I tried to find data that says, oh yes, the START system, which is the one most widely used in the United States, clearly triages people into, like the way we want, right? In the pre-hospital settings. But actually, it turns out that most of the studies have not been super well done, and they've used all kinds of different methodologies to do them. Though there's actually only one study, which was not huge, that I thought did what I wanted it to do, or that I thought the study did what I wanted the study to do. How's that? And it did say that there was a tendency towards over triage, but but when we're triaging, what we're doing is going through and organizing a scene as quickly as possible. And what happens is when the people get to the hospital phase, then you expect the people in the ED or the ER to do a better evaluation and figure out that the person with the fast respiratory rate who is just anxious is not actually severely injured. But actually I was surprised, considering that the system was developed in the 80s and is widely used in the United States, that there's not better data to show that it is actually effective. Does that answer that? So yeah, that was I was actually really surprised by that. I thought by now there would be better data. Okay, so here are the CERT takeaways, and they are your safety is paramount. We say that in every, I hope, in every lecture. We want you to wear the proper PPE and don't begin medical treatment until you and your patient are safe. We want you to remember the 3 killers: obstructed airway, life-threatening bleeding, and shock, and remember some treatments for all of those. And these are recommendations for what to do after listening to this lecture. Well, we want you to consider looking into taking another sort of first aid class, because a lot of what we do in CERT, where medical is concerned, is relatively minimal, and you're certainly going to learn a lot from other agencies such as the Red Cross or the Stop the Bleed. And then this is pretty simple that everybody can do: put a couple of pairs of non-latex medical gloves in your everyday carry bag. All right. So sadly, as recent events have shown, you are more likely to need your stop the bleed skills than you are to need your massive earthquake skills.